So we're going to continue with respiratory disorders by looking at restrictive lung disorders. Now, restrictive lung disorders are anything that stops the lungs from fully expanding. So reduces the total lung capacity and therefore reduces the other capacities and volumes. This could be a problem of the chest wall. So that could be things like scoliosis or kyphosis. It could be something to do with neurological restriction of the respiratory muscles, like Lou Gehrig's, ALS, or polio, or it could be due with muscular problems like muscular dystrophy. The other group are groups that they're diseases that affect the physical structure of the lung itself. So idiopathic pulmonary fibrosis and occupational lung diseases fit this second group. Okay. A lot of times, especially long-term exposure to dust, results in irritation within the lungs itself. And that causes inflammation. And that can turn into chronic inflammation, which is histological change. And really, it's kind of an insidious growth of problems and functional lung loss. So a lot of industrial lung diseases fall into this category. Pneumoconiosis. So anthracosis is breathing in coal dust, and people who work in coal mines do it. Silicosis, hard rock mining, stone cutting, sandblasting, that kind of things from breathing in silica. Both my grandfathers died of the silicosis because they were both underground miners. They both worked in gold mines. Asbestosis is from breathing in asbestos dust. I've got relatives that have worked in asbestos mines, but it's more common in people that used to work in asbestos insulation and that kind of thing. Working with hay, breathing dust from hay, we call it farmer's lungs, and it can be fungal in nature, or it can just be the dust itself. I'm going to go back up to here. Idiopathic pulmonary fibrosis is idiopathic. We don't know what causes it. This is actually what my father died from. There's probably a genetic component to it. My aunt, his sister, died 48 hours to the minute after my father died of the same disease, idiopathic pulmonary fibrosis. It's probably got something to do with the way that the inflammation in the lungs gets out of control from breathing in things. But again, it's idiopathic. One of the things that I used to describe, because my father-in-law died of COPD, and I had to explain the difference to a lot of family members. In the COPD, it's obstructive, so he had emphysema, and that is an increase in the dead space. So although ventilation is obstructed because of the loss of the walls, there was less surface area that could be involved with gas exchange. Whereas pulmonary fibrosis, it's um, it's like the restriction, the lung itself just physically couldn't inflate because of scar tissue. Um, so in effect, it limited the amount of air that you could bring in, and therefore limits the gas exchange. So that while there's similarities, they're almost at the opposite end of the spectrum. Okay, there's lots of vascular disorders that happen in the lungs as well. Pulmonary edema is reasonably common. It's fluid collecting in the alveoli, but also in the interstitium. Lots of primary conditions, lots of things can result in pulmonary edema. So if the edema is in the interstitium, especially, it can be a restrictive disease. You can't physically expand the lungs because the interstitium is edematous. If it's fluid collects into the alveoli, then the amount of oxygen getting diffused, getting exchanged with the external respiration is limited that way. So inflammation in the lungs will do it because inflammation causes increased permeability and more fluid. If you remember PRISH, it's just inflammation. There's edema goes with it. Plasma protein levels low affects. So this is albumin. It affects the osmotic flow, and so not as much fluid gets drawn back into the bloodstream. The hydrostatic pressure pushes fluid out of the bloodstream into the interstitium. Osmotic pressure brings it back. If there's low levels of albumin, then that doesn't happen efficiently, and you end up with edema kind of everywhere. This could be an issue of the liver, because liver is where albumin is made, things like that. No matter what, another thing could be pulmonary hypertension. For whatever reason, if there's on the pulmonary side, there's high blood pressure, it's going to increase the hydrostatic pressure and push more fluid out of the blood and into the interstitium of the lungs. So high hydrostatic pressure, pulmonary edema, we end up with interstitial fluid accumulates because it goes in from the interstitium, end up with hypoxemia. So you're going to have cough, blood pressure issues. It's going to be difficult to breathe laying down. There's going to be sounds. Sometimes you're coughing up blood. There's going to be air in the sputum, right? But it's hypoxemia and cyanosis towards the end. So you have to figure out what causes it and treat that and try and eliminate the cause of it. Using ventilators helps, positive pressure, mechanical ventilation. So all of this stuff is supportive. Okay, a fairly common thing is pulmonary embolism. I had one of these about a year and a half ago. It's blood clots that obstruct a pulmonary artery. So if it's a large clot and it blocks a large location, it can be quite a problem. If it's a small emboli, it will have less effect because it causes ischemia in a much less area. It can be a cause of death. So one of the things to understand is that blood clots anywhere on the venous side of systemic circulation. So in any veins, so anytime after any of the capillary beds, you have a thrombus, you have a clot forms. If that clot breaks free, it will move along the venous side of circulation with every vein getting larger. So little small venules join together to make a bigger vein, and small veins join together to make medium-sized veins, and then they come together to make large veins, which eventually end up in the vena cava, and they go through the right side of the heart, and then they exit via the pulmonary artery. And arteries always get smaller, so a large pulmonary artery branches into smaller and smaller and smaller and smaller until it gets to the arterioles, feeding the capillaries in the lungs. Well, the place that the clot lodges is the place where the lumen is smaller than the clot. So any thrombus, deep vein thrombosis that happens in your legs, for instance, the next place it finds a narrow lumen is the lungs. So usually these pulmonary emboli start in the veins, and it's usually a DVT in the legs. Now this is different than ones that form in the heart valves, or which is a commonplace, and then the clot enters the aorta, and then maybe the coronary or the coronary arteries, or maybe goes up the carotids, and can cause strokes and things like that, ischemia further beyond. I find it interesting that even as I was having a DVT and a pulmonary embolus, I was at the hospital and I had nurses say to me, "Oh, you're lucky that it went to your lungs and didn't cause a stroke or something like that." Well, it can't. A DVT goes to the lungs. The next narrow spot is the lungs. Arterial clots are a different thing. Okay, so if the emboli is small, you have some chest pain, maybe transient. It's difficult to breathe. You get coughing. Larger emboli cause big chest pain, rapid shallow breathing, difficult breathing, and you can start coughing up blood. And you get a sympathetic response, you get anxiety, restlessness, tachycardia, all of that kind of goes with it because it's painful. When it happened to me, I thought that I'd hurt a rib because it was feeling like intense pain every time I took a deep breath. And I'd been working out, and I was certain that I had just strained a rib until I started coughing up blood. Very scary thing. If it's a huge emboli, you get crushing chest pain, blood pressure drops really quick, you get a weak pulse, loss of consciousness, and likely death. So, compression stockings help this. Anticoagulant drugs help it. It turns out that they called mine provoked because I had hurt my leg. I banged my calf. I had a big bruise on my calf, and I ended up with the DVT in that spot. So I was only on anticoagulant medication for 6 months because they don't feel from doing blood work and other tests that I have a clotting problem. But I still wear, like if I go on an airplane, I wear anti-embolic stockings. So I wear compression socks to increase the blood flow and prevent clots from happening. Making people aware of it is a good preventative thing. They found mine with an MRI. And that's the way that it's usually found. Right? So assess the risk factors. Sometimes if it's happening a lot, putting a mesh filter into the vena cava will collect those clots and prevent them from going any further. That's a fairly common thing. The heparin, that kind of thing, is all about busting up clots. So you can just follow this, but the clot comes from the leg, passes to the right side of the heart, and lodges in the blood vessels of the lungs, the pulmonary arteries, at wherever the lumen is the same size as the clot. Okay, there's problems. These are the expansion disorders, so pneumothorax, pleural effusion, atelectasis, flail chest are kind of in this category. So atelectasis is non-aeration, it's lung collapse. Might just be part of the lung. When that part of the lung collapses, there's obviously not going to be any gas exchange happens there, and it leads to systemic hypoxia. The alveoli, because the walls of the interstitium are elastic, unless there is a positive pressure, just like a balloon, they deflate. And so the alveoli lose their air. It can cause inflammation, and that becomes a whole other issue. Because of ventilation perfusion coupling, any place that you can't send air, you don't send blood. And so this will back up on the to the right side of the heart. You'll end up with a pulmonary hypertension from this because ventilation and perfusion are impaired. So there's a couple of reasons that it happens. So if there's a total obstruction of the airway going to an area, then what happens is the gases in the alveoli diffuse into the interstitial fluid, and literally the gases are not replaced, and so gas levels go down until there's not enough to keep the alveoli inflated. Another cause is some sort of a mass, usually a tumor, puts pressure on part of the lung, and that affects the the negative pressure that holds the lung open. Normally, the pressure in the pleura is about 4 millimeters of mercury less than the pressure in the alveoli, and therefore uh, the alveoli stays inflated. Increase the pressure on the outside, and that difference doesn't exist, and the elasticity takes over, and the lung collapses. Hopefully, you've learned about surfactant, the chemical that break the surface tension within the alveoli. If there's not enough surfactant, then the surface tension of the liquid in the alveoli, the water, literally increases the pull and the elasticity of the alveoli. And if it overcomes the tendency to be expanded, then lung will collapse. A friend of mine who also happens to teach at the college over in the engineering department, he was a very competitive swimmer, and when he was younger, and he started having lungs collapse on a fairly regular basis. And the reason that he did was because he was breathing off the surface of these pools, like an inch or two off the surface of the pools, for vast amounts of time. He was breathing in a lot of chlorine, and the chlorine killed the type 2 cells in his alveoli, which meant that his production of surfactant went way down, and he started having spontaneous atelectasis and had to have it surgically repaired. So, fibrotic tissue restricts expansion and can lead to collapse. It can happen after surgery, especially because of inflammation and things like that. So, but the lung is intact. What happens is the pressure differential is what changes. So if it's a small area, it's asymptomatic. If it's a large area, it's difficult to breathe. You get chest pain, you get inflammation in the area. So it's trying to remove the cause is the or the blockage is what you do to treat it. Pleural effusion is when the pleural cavity starts to accumulate excessive amounts of fluid. Now, there's always a little bit of fluid in the pleural cavity, but if it becomes excess, then that's going to increase the pressure within the pleural cavity, because this is in the space between the two pleural membranes. And that increased pressure, if it gets up to atmospheric pressure, can cause atelectasis. It can happen because of inflammation and exudate going in there. Or it can be transudate. It can just be kind of almost like edema. So if it's water, we call it hydrothorax. And it could happen because of increased hydrostatic pressure, blood pressure, not in the pulmonary arteries, but in the bronchial arteries, the systemic side, which is what the arteries that feed the pleura. It can also happen because of a decreased osmotic pressure, so liver disease and things like that that decrease the osmosis, not making albumin, can happen. When it happens, it's very difficult to breathe. When you percuss it, there's a dullness there. You can't, like you're tapping bag that has water in it. It can actually start to push the lung over if there's enough, and the trachea will deviate as well. So chest drainage is the thing. You have to remove fluid, relieve that pressure, analyze the fluid, confirm what's causing it, and then repair if you can. That. Okay, pneumothorax is air getting into the pleural cavity. So, like I showed you in class with the demonstration with the bottle, if there's a way for the pleural pressure to equalize to atmospheric pressure, then the lungs will collapse. So air enters the pleural cavity from a couple of ways. So one of the ways is internal airways, plebs, and somehow there's a connection is made between the air in the alveoli and the pleural space, and air will rush in to the pleural space because it's at a lower pressure than the alveolar pressure. It could be because of a tear on the surface of the lungs. It could be secondary to emphysema and the blebs on the lung surface. It could be erosion from lung cancer and a tumor. It could be from tuberculosis and the cavitation, the necrosis caused by tuberculosis. It also can happen because of an opening in the chest wall. These are the things that you're going to see as paramedics after stabbings and gunshots and car accidents and things like that. So that's a puncture through the wall, and we call that an open pneumothorax. Closed pneumothorax is blebs and things like that from the inside. Right? Both of them cause atelectasis, right? The thing about a closed one is that as that part of the lung collapses, it usually seals the leak. It usually only affects one lung or one side, right? The open air enters from the pleural cavity with each inspiration. As you breathe in, not only are you sucking air into your good lung, the one that's not collapsed, but as the chest wall expands, the pressure in the chest wall goes down and air sucks in through the hole from the outside into the pleural space. If that hole is open, then exhaling pushes that air out, and it's kind of like almost like breathing through the hole, except it doesn't get into the lungs, it gets into the pleural space. So the as long as that's happening, you get this this sucking noise, right? If a lot of air is coming into that space, because it's easier to move air into that space than it is to move it into the lungs, then what it can do is it can literally push the mediastinum over and start to affect the unaffected lung by increasing the pressure on the pleura there. A tension pneumothorax is much more of a big deal. Either whether it's open or closed, what happens here is that the opening for the air coming into the pleural space has a flap on it. And so air can enter the pleural space, but it can't exit. So there might be a puncture with a flap on it that acts like a one-way valve, like maybe a skin or something like that. So it's usually some sort of an oblique wound. When you breathe in, air goes into the pleural space. When you breathe out, the air can't escape. The next breath in, more air goes in. Next breath out, it can't escape. Even more comes in. And what this does is it pushes the mediastinum over. And the unaffected lung gets increasingly compromised by this shift. This shift can also reduce the venous return to the heart, but that's a whole other thing. What can happen if it's bad enough is that the unaffected lung can collapse because of the pressure from all this air on the opposite side, pushing the mediastinum over all the way. It's pushing the heart and it's impairing the heart, but it's also pushing against the other lung and the other pleura, increasing the pressure in that pleura, and can cause atelectasis on the other side. It's a very scary thing. What has to happen is the pressure within the collapsed side has to be equalized. The air has to be able to escape. There has to be that flap has to be opened, that one-way valve, and that air has to escape. So we have to go from a tension pneumothorax to an open pneumothorax, kind of thing. You end up with this tracheal deviation, because as the mediastinum gets pushed over, the trachea deviates to the unaffected lungs side, because the collapsed lung pleural space gets bigger and bigger and bigger and pushes the mediastinum away from it. When you see that, it becomes a major thing. The compression on the pericardium from this also means that venous return is impaired. And so you start to get distended veins, especially in the neck. And you end up with cyanosis, hypoxemia from impairment of the heart. So the open atmospheric air enters, so it's a sucking wound. Tension is with this one-way valve. The lung collapses, you have difficulty breathing, cough, chest pain, breath sounds reduced on that side, unequal chest expansion, hypoxia, interference with venous return, and so you end up with hypotension and you end up with distended veins, especially in the neck. So it's an emergency. So you transport as soon as possible. The sucking wound, you cover it and occlude the air going in and out. You don't want to remove any penetrating objects, because it can take an open pneumothorax and make it into a tension pneumothorax. If the flap is being held open by the wood splinter or whatever, the piece of metal, then you're not going to get the tension. As soon as you take that out, you're creating the flap that's going to give tension pneumothorax. Enlarge the opening if it's a tension pneumothorax. I'm sure that you're going to cover this in great detail in your practical courses. Flail chest is when ribs break, and ribs move independently during respiration. Normally speaking, in inspiration, as the diaphragm moves down, the pressure in the chest decreases because the space gets bigger, and air goes into your lungs, right? Because the ribs are holding the space open. In flail chest, because of the broken ribs, as the diaphragm pulls down, it creates a lower pressure, but rather than sucking air into your lungs, it sucks your ribs into the chest. So you have this paradoxical movement. The broken sections of ribs move inward rather than outward with the breath. And the lung on that side can't expand. Right? It's it can become a real problem of breathing. Now, what can also happen is if the ribs are pushing, it pushes air that's in that lung up to the bronchus, and it can cross into the primary bronchi of the other lung and um, and affect the amount of carbon dioxide that's in that lung. So this unstable section, you can't get the intrathoracic pressure to make that side of the lung work. So you end up with hypoxia. And here's a picture of. So infant respiratory distress, it's got something to do with a lack of surfactant in the alveoli. It's usually preemies. A fetus doesn't breathe. They're in the womb, and they get their oxygen and nutrients through the umbilicus. So it makes no sense for the lungs to develop early in gestational development. The lungs are kind of the last things to develop, and the type 2 cells in the alveoli that produce the surfactant are the very last thing that happen to prepare for the breathing. If the baby's born 3 or 4 weeks premature, then the surfactant capabilities are probably not ready. So that means that there's too much surface tension, and it's very difficult. The compliance of that infant's lungs are way down and can cause atelectasis in different places, decreased pulmonary blood flow. So it leads to hypoxia. It can lead to pulmonary hypertension, that kind of thing. Because the lack of surfactant means that there's no ventilation, then there's poor perfusion on that side as well. If fluids and proteins leak into the interstitium, then that can lead to osmotic problems and pulmonary edema as well. So respiratory difficulties at birth, shallow, rapid respiration, frothy sputum, cyanosis, right, hypoxemia, periods of apnea, that kind of thing happen. So what do we do? If we know people are in premature labor, we give them steroids. We give them glucocorticoids, prednisone. Probably when the baby is born, you put them in an incubator and you infuse synthetic surfactant into the incubator so that the air that the baby's breathing contains surfactant. If it's bad enough, we may have to use positive pressure, so a CPAP type of thing. Increase the oxygen levels is another thing. Nitrous oxide to cause bronchodilation and make it as easy as possible, probably work as well. This is one of the reasons why, to prevent infant respiratory distress syndrome, that neonates, preemie neonates, are just automatically put in an incubator and has surfactant introduced until we're certain that the baby is breathing well on its own. Adult respiratory distress is got something to do with injury to the alveolar wall or the capillary membrane. So the respiratory membrane is the alveolar wall, the type 1 cells, and the squamous epithelial endothelial cell of the capillary. So if there's injury there, you get chemical mediators, it's inflammation. So it increases the permeability of the capillary membranes. So fluid and protein go into the interstitium and into the alveoli. It can damage the type 2 cells, the surfactant producing, and eliminate surfactant. You can end up with necrosis. You can end up with fibrosis from it. Lots of lots of conditions that predispose, so organ dysfunction, liver dysfunction, things like lupus and autoimmune diseases, all of these things can lead to this adult respiratory distress syndrome. Difficulty breathing, restlessness, shallow respiration, increased heart rate, metabolic acidosis and respiratory acidosis combined. So it's difficult to compensate for the metabolic, and you end up with some respiratory. So it's usually secondary to something else. So treatment of the something else helps. Supportive respiratory therapy is, ventilators, things like that. So something is injuring the capillary walls, the alveolar walls. So you get increased permeability, fluid leaks, you have pulmonary edema, decreased compliance, and then maybe atelectasis, and whatever leads to respiratory failure. The cell damage to the capillary wall causes, or to the alveolar wall causes decreased surfactant, which is decreases the compliance, which can lead to respiratory failure. Acute respiratory failure is when breathing stops. It's acute disorders, could be neuromuscular diseases. It's often secondary to something else, emphysema, other disorders, multiple organ disorders, and that kind of thing. It's really not a disorder on its own. It is symptomatic of other disorders, but it's part of management of the patient with that primary problem. So you support respiratory function while you treat the other disorders.